Potassium disorders are extremely common electrolyte disturbances that you're going to encounter in your clinical practice, and one of the very favorite areas for the examiners as well in the exams to ask questions from. In the previous section, we have discussed extensively on hyperkalemia. In this particular section, we are going to discuss extensively on hypokalemia with regards to its etiology, clinical features, workup, as well as the management part. Without wasting much time, let us start with the etiology of hypokalemia. As far as the etiology is concerned, we know there are three major players that are going to help in potassium homeostasis in the body. One is going to be the GIT. Second is going to be the intracellular fluid, which is very important for the short-term regulation of potassium homeostasis in the blood. And finally, you have the kidneys, which are very, very important for the long-term regulation of the potassium homeostasis. So let us start with the GIT causes or gut causes of hypokalemia. Hypokalemia resulting due to reduced oral intake of potassium is extremely uncommon, and you're not going to really result in hypokalemia because of this alone unless until there is problem in either intracellular regulation of the renal regulation of potassium excretion. Because kidneys actually can compensate for the reduced intake of potassium by reducing the excretion of potassium to as little as 5 milliequivalents per day. Normally, kidneys excrete approximately around 15 to 20 milliequivalents of potassium per day, but they can actually reduce to less than 5 milliequivalents per day in the setting of low oral intake of potassium. So, just because of reduced oral intake, getting a hypokalemia is extremely uncommon and rare. And at the same time, there is a condition called geophagia, which has been published in the literature as one of the causes of hypokalemia in occasional, rare and sporadic cases, especially when people tend to eat this white clay, which is a very poor source of potassium. They're eating too much. That might actually result in an occasional hypokalemia case. But apart from that, you don't really result in hypokalemia because of reduced oral intake. But there is another entity called a red clay. And eating a red clay will not result in hypokalemia because red clay is actually rich in potassium. So that's not an issue. Apart from that, the colon is a very, very important source of potassium because it secretes potassium. Remember, usually potassium secretion happens maximally in the colon, even though it is negligible. But in the long run, over a period of time, it can actually result in hypokalemia if the colonic potassium that is secreted is getting wasted rather than getting reabsorbed in the colon. So what are the conditions that wash out this colonic potassium that is getting secreted? So obviously, as you expect, the first one is the diarrhea and conditions that resemble diarrhea like a laxative abuse. So can result in hypokalemia. One of the most important electrolyte disturbances that happen in a patient with laxative abuse is hypokalemia. That is because of the washout of the secreted potassium from the colon. Second, you can result in hypokalemia due to villus adenoma because villus adenoma is basically secretory and they do secrete potassium, and we'll be discussing about these adenomas in detail in the gastrointestinal section. And apart from this diarrhea and villus adenoma, we have certain conditions like colonic obstruction, which can also result in hypokalemia because in obstruction, the bowel will be dilated, and because of colonic irritation, they will be secreting more potassium into the lumen. But actually, the potassium is there in the lumen, but it is not in the body. That's why you result in hypokalemia. We're talking about a mechanical obstruction in this regards. Number 4, you have another condition called a colonic pseudo-obstruction, which is otherwise termed as a Ogilvie syndrome. So Ogilvie syndrome is a picture that is resembling a colonic obstruction, but in the absence of any mechanical cause. So that's what we call as a Ogilvie syndrome, which happens in extremely ill, critically ill patients. Just the colon becomes dilated massively to a great extent, and it might resemble a toxic megacolon, but it should not be called as a toxic megacolon, but it will be called as a acute megacolon for that matter. The colon will be dilated to a huge extent, but there will be no actual mechanical obstruction in these patients, and the mortality rate is very high. And these patients tend to have more potassium in the lumen because the colon starts secreting the potassium and it will be in the lumen, but it will not be in the blood, once again resulting in hypokalemia. So these patients tend to have hypokalemia along with other electrolyte disturbances like hypomagnesemia and hypocalcemia as well. And in patients who are having a true mechanical colonic obstruction and a colonic pseudo-obstruction, tends to have high potassium actually in the lumen of the colon, but that is actually coming from the body, and that is the reason why the total body potassium will be low, because it's in the lumen and not in the body, and that's why it results in hypokalemia in this setting. And here are some extracorporeal causes of hypokalemia, where potassium is removed extracorporeally from the body, resulting in depletion of the total body potassium, causing hypokalemia. The first cause obviously is going to be the dialysis. Post-dialysis hypokalemia is very common, even though whether you treat it or not is a big question. It depends. And at the same time, after plasmapheresis and plasma exchange, you can result in hypokalemia as well. Both are due to extracorporeal removal of potassium, depleting the total body potassium. And let us move on to the cause of hypokalemia due to excessive intracellular uptake of potassium. And it's going to be really transient, but even though it is going to be very significant, it can kill the patient as well. One of the most important regulators of intracellular uptake of potassium is going to be the sodium potassium ATPase. We know that. We have discussed multiple times, and we are going to discuss time and again as well. And the sodium potassium ATPase is going to take up potassium, 2 potassium ions into the cell, and they are going to release 3 sodium ions outside the cell into the extracellular fluid. And conditions that are going to stimulate the sodium potassium ATPase can well result in hypokalemia, and we know that. So what are the conditions that stimulate the sodium potassium ATPase? And one of the very, very important conditions that stimulate the sodium potassium ATPase is going to be insulin. So hyperinsulinism mediated hypokalemias are extremely common in the society. This is very, very common, especially when the patient is getting some insulin therapy. Especially when you're using IV insulin, the shift is going to be very, very rapid than subcutaneous insulin. So IV insulins are going to be more dangerous with regards to hypokalemia compared to that of the subcutaneous insulins, which act relatively much slower than the IV insulin. This is very relevant, especially when you are doing a treatment for diabetic ketoacidosis or hyperosmolar hyperglycemic state, or in critical care setting when you're using insulin infusions. That time it's going to be really, really important. Apart from that, there is a condition called refeeding syndrome, which is again due to excessive insulin related hypokalemia. So it's better to know that as well. And the second condition is going to be the beta-2 receptor stimulation. We also know that this beta-2 receptor stimulation results in activation of the G-stimulatory pathway in cyclic AMP, which is going to activate the sodium potassium ATPase and thereby resulting in more cellular uptake of potassium. So conditions and drugs that are going to aberrantly and excessively stimulate this beta-2 receptor can actually result in hypokalemia. So we have two conditions. One, exogenously, certain drugs can stimulate the beta-2 receptors. In this setting, we have to remember albuterol, that is nothing but salbutamol. Then you have terbutaline, which can stimulate the beta-2 receptor and the related pathways. And you can remember theophylline under this setting as well, especially in the setting of theophylline toxicity. But theophylline is not a direct stimulator of beta-2 receptor, but it actually augments the pathway that resembles like a beta-2 receptor stimulation. Because theophylline is a non-selective phosphodiesterase inhibitor that increases the cyclic AMP levels inside the cell, which can resemble like a beta-2 receptor stimulation, thereby causing hypokalemia. But the most clinically relevant are the insulin and the salbutamol, so which is actually used in the therapy for hyperkalemia, especially acute hyperkalemias, life-threatening hyperkalemias. We use these therapies to immediately lower the serum potassium, which we have discussed extensively in the previous chapter itself. Apart from that, there are some drugs like ephedrine and pseudoephedrine can do the same, but even though these drugs in the current practice is very rare, but this also can cause hypokalemia. And endogenously, if there are excessive catecholamines, they can also stimulate the beta-2 receptor, resulting in hypokalemia. Catecholamin excess you can see in patients with alcohol withdrawal, very commonly in the public, which is a state of catecholamin excess, or you can see in patients who are having pheochromocytoma, or patients who are suffering from acute myocardial infarction or head injury, which is a setting of catecholamine excess once again, because it's a flight, fright and fight reaction. It's a stressful scenario in the body. And thyrotoxicosis, do not forget that, can result in hypokalemia. Because thyroxine is a hormone that's going to augment the sympathetic pathway, that is augment the catecholamine related pathways inside the cell. So thyrotoxicosis obviously can stimulate the sodium potassium ATPase causing hypokalemia. So alcohol withdrawal, pheochromocytoma, acute myocardial infarction, head injury, thyrotoxicosis. This is due to excessive endogenous catecholamines causing hypokalemia. Then we all know there is another condition called alkalosis that can result in increased intracellular shift of potassium. So alkalosis state of excessive pH means it's going to have a low H+, so the cell is going to release H+ to compensate for that, and they're going to take up potassium into the cell, resulting in hypokalemia. We saw that mechanism in detail in the potassium homeostasis chapter itself. There is a dictum that for every 0.1 unit increase in the pH during alkalosis, there will be a simultaneous drop in 0.4 units in the serum potassium in milliequivalents per liter. Clear? So for 0.1 unit increase in the pH, that's going to be decline in serum potassium by unit of 0.4. And this is clinically relevant, especially in the setting of acidosis. When you are using an alkalotic agent, this is more relevant compared to a patient who's having a normal pH and you're inducing an alkalosis. And very rarely, there are some conditions that actually block the outward exit of potassium. So which means I can write there are conditions that reduce the potassium exit from the cell and thereby resulting in hypokalemia. So first condition, hypothermia, can reduce the potassium exit through the potassium channels, resulting in hypokalemia. And there are some drugs which block the potassium movement from the cell by blocking the potassium channels. Like for example, especially in intoxicated states of these drugs like chloroquine intoxication, antipsychotic intoxication, antipsychotic overdose, or patients are having barium or cesium intoxication can result in hypokalemia by this principle. Like I described in hyperkalemia, where I described an entity called pseudo hyperkalemia, we have an entity called pseudo hypokalemia as well, which means it's a in vitro hypokalemia or a test tube hypokalemia, but there is no in vivo hypokalemia. There are two different conditions that are associated with this pseudo hypokalemia. One is due to increased blood cell production. And in this condition, the blood cells will be so active that even after removing the sample, after drawing the blood, the test tube cells will be so active and the sodium potassium ATPase will be so active so that they can gobble up more potassium, causing a false hypokalemic picture in the blood. So this can happen in the setting of AML and CML, which is generally going to be associated with other electrolyte disturbances like pseudo-hypoglycemia and pseudo-hypophosphatemia as well, due to increased cellular uptake even after drawing the blood. And it can happen in the setting of GCSF or GMCSF therapy for neutropenia. And the same mechanism can be extrapolated to patients who are receiving B12 and folic acid therapy for megaloblastic anemia, where there will be rapid cellular proliferation causing hypokalemia. Apart from that, there is another entity called a seasonal hypokalemia. So where the blood is drawn from the patient and it will be kept in areas with increased ambient room temperature, and that can activate the sodium potassium ATPase, resulting in more cellular uptake and hypokalemia. That is due to increased room temperature after drawing the sample, activating sodium potassium ATPase, causing hypokalemia in the sample but not in the, actually not seen in the patient. And we have another entity and a genetic condition that is going to result in paralysis because of excessive cellular uptake of potassium and hypokalemia, called as hypokalemic periodic paralysis, which is a very, very important question as far as exams are concerned. But it's a very, very rare case that you're going to encounter in your clinical practice, but can be seen occasionally in a tertiary care center. And it's an autosomal dominant condition. It's going to be inherited as an autosomal dominant fashion with varying degrees of penetrance. So it's not a high penetrance or a low penetrance, it's a varying penetrance. And you have to know the mutation. So 90% of the times, the mutations will be in the alpha-1 subunit of the calcium channel. So this is an alpha-1 subunit of the calcium channel. These are nothing but dihydropyridine sensitive calcium channels. And please do remember the fact this alpha-1 subunit is the major subunit for this dihydropyridine sensitive calcium channel. So mutations of this can result in hypokalemic periodic paralysis, as well as another condition called malignant hyperthermia, rarely because this CAC NA1S dependent calcium channels interact with the ryanodine receptors as well. So I'm not going to discuss about that. So 90% of the times, most common mutation in hypokalemic periodic paralysis, this alpha-1 subunit of dihydropyridine sensitive calcium channels. And 10% of the times, the mutations can be seen in the skeletal muscle sodium channel called SCN4A channel, which is the same channel that has been implicated in hyperkalemic periodic paralysis as well. But the mechanisms behind how this calcium channel problem resulting in slow calcium influx into the cells causing hypokalemic periodic paralysis is largely unknown. We really don't know that, even though research is still going. But this is well understood. The SCN4A problems resulting in hypokalemic periodic paralysis, the pathophysiology behind that is well understood. Problems in this SCN4A channel, the mutations will result in the formation of something called an aberrant gating pore. There's an extra pore, additional pore, that slowly leaks potassium into the muscle for a long time. So if there is continuous leakage of sodium into the muscle, apart from getting swollen and later on going for fibrosis, that is different. That is going to continuously depolarize the muscle, and the muscle will go for fatigue over a period of time, and they will result in episodic weakness after some point of time. And this extra sodium that is coming into the muscle is going to be a trigger for stimulation of the sodium-potassium ATPase, and which is going to push the sodium outside and move the potassium in. Thereby, you can explain the hypokalemia due to increased intracellular shift of potassium as well, resulting in paralysis of the muscle. So SCN4 related problems, yes, you can explain, but calcium channel related problems causing hypokalemic periodic paralysis is still not clearly understood. What will be the clinical features in this condition? Obviously, there will be episodic weakness. That's why it's called a periodic paralysis. And this episodic weakness is usually associated with a precipitous fall in the serum potassium. And there will be a hypokalemia whenever the patient comes with this episodic weakness. And the characteristics will be upper limb will be involved more than the lower limb. And of course, proximal weakness will be more than the distal weakness because it's a muscle related issue. And there will be increased incidence of bulbar and respiratory weakness. And this is a very crucial point because bulbar and respiratory weakness are not seen in a patient with hyperkalemic periodic paralysis. And you don't have a myotonia here. That's a very important differentiating point because presence of myotonia usually goes towards a hyperkalemic periodic paralysis, but in hypokalemic periodic paralysis, you don't really get a myotonia for that matters. And attacks can be precipitated, which means there are some things which can precipitate these attacks. Attacks can be precipitated by a rest period followed by, following an exercise. So when you're doing an exercise followed by a rest, and that's a classical history that you're going to get in most of the patients, which precipitates the paralysis. And apart from that, increased carbohydrate diet, very, very important, and increased sodium diet can precipitate the attacks. And sudden changes in the environment also can precipitate the attacks. For example, a loud noise, a sudden flash of light, changes in the temperature suddenly also can precipitate this attack. Sudden changes in the environment can precipitate the attacks. And administration of glucose containing solutions, because glucose will increase the insulin release, that will precipitate more and more hypokalemia, and these patients can go for paralysis. Administration of glucose and administration of glucocorticoids and administration of insulin, because glucocorticoids increase glucose and that can be a stimulus for insulin release. And administration of insulin itself, all these things can precipitate development of hypokalemia due to increased intracellular shift of potassium and resulting in sudden paralysis in these guys. There are some associated conditions with hypokalemic periodic paralysis. The number one being Anderson syndrome. As I told you before, Anderson syndrome can be associated with both hyperkalemic as well as hypokalemic periodic paralysis, and these patients additionally will have long QT, which is a risk factor for sudden death, and these guys can die suddenly because of the long QT and the resultant ventricular tachyarrhythmias. And there is another entity called thyrotoxic periodic paralysis, which is also a form of hypokalemic periodic paralysis. How will you differentiate thyrotoxic periodic paralysis from Anderson syndrome? And these patients will have picture that is similar to hypokalemic periodic paralysis. Apart from that, they will be having hyperthyroidism. Along with that, due to unknown reasons, they also tend to have this elevated bone-specific alkaline phosphatase. And this is not really seen in all the patients with thyrotoxicosis, but patients with hypokalemic periodic paralysis, that is thyrotoxic periodic paralysis and having thyrotoxicosis, generally tend to have elevated bone-specific alkaline phosphatase, and we don't really understand why this elevated BSAP is there in these guys. And diagnosis is based on electromyography that is done either during the time of attack, or you can ask the patient to exercise and you can see the changes in the electromyogram. That is weakness that you will be able to demonstrate in these patients at that point. And treatment wise, the most important treatment is going to be potassium supplementation. And potassium supplementation should be slow and low. Why I am telling it should be slow and low, and it should be very slowly, and we have to give a low dose of potassium. The reason is because it's a intracellular shift related hypokalemia, and obviously after some time this potassium that has been shifted intracellularly is going to come out and leak into the extracellular fluid after some time, but not immediately. So there is a risk of rebound hyperkalemia. So that is the reason you have to always go slowly and you have to give a low amount of potassium, a low dose of potassium to prevent rebound hyperkalemia in this setting. And whether you will give IV potassium or oral potassium depends. Suppose if the patient is able to take orally, then you can give oral potassium. But if the patient is not able to take orally in the setting of bulbar weakness, or the patient is having severe problems like respiratory weakness and respiratory failure, in this setting you can prefer IV potassium also. Commonly used solution is IV potassium chloride. But you have to be a little cautious when you are using IV potassium. Make sure that you do not use any dextrose or glucose containing solutions, and you do not use any sodium containing solutions as well, because both are triggers for more hypokalemia. As I told you before, increased sodium diet can precipitate the attacks. At the same time, anything that lowers the potassium like insulin and glucose is actually a problem, and that is the reason why do not use this potassium chloride in a dextrose containing solution or even a sodium containing solution. The best diluent as far as potassium infusion in patients with hypokalemic periodic paralysis, mannitol. Generally we give with mannitol only. But regularly in other patients with hypokalemia, we prefer NS as a preferred solution, normal saline as a preferred solution, or plasma late, other solutions that contain sodium as a preferred solution for infusing potassium. But in this setting, avoid sodium containing solutions and glucose or dextrose containing solutions and prefer mannitol as a diluent. That's the most important point that you have to know. And there are some drugs that are used to prevent hypokalemic periodic paralysis, which means prevent these attacks. So these drugs actually prevent the movement of potassium into the cell. So that is how these drugs work. So simply you can use potassium supplementation also in the longer run. And you can give a low carbohydrate diet. You can ask the patient to take a low carbohydrate diet. And you can give certain drugs like beta blockers, especially non-selective beta blockers can reduce the movement of potassium into the cell by the mechanism which you have described already in the previous sections. And we can use certain drugs like potassium sparing diuretics because they also prevent the precipitous fall in the serum potassium. And carbonic anhydrase inhibitors also do work, and this is a very, very commonly used drug for hypokalemic periodic paralysis in a tertiary care setting. But how this exactly works still to be elucidated, but still it works very nicely. Examples of these drugs being acetazolamide, and an off-label drug that can be used is topiramate. Topiramate and zonisamide are anti-epileptic drugs, but with carbonic anhydrase activity, we know that. So these are the drugs that can be used for the same purpose as well. Clear? So hypokalemic periodic paralysis is a very, very important question as far as exams are concerned. So please be very thorough about that. So the most important point being episodic weakness along with hypokalemia during the time of attack. They may or may not be associated with thyrotoxicosis, doesn't matter. If the patient has thyrotoxicosis, obviously you will have a hyperthyroidism picture under elevated bone-specific alkaline phosphatase, and there is an increased risk of developing bulbar and respiratory weakness, and that is something to be known because this is the one that clinically differentiates your patient from a hyperkalemic periodic paralysis. And at the same time, use mannitol as a diluent and don't use glucose or sodium containing solution. These are the exam areas that you have to concentrate. Now let us move on to the kidneys, because we have completed the ICF dysregulation causing hypokalemia. Now we are moving on to the kidney problems causing hypokalemia. As I said for multiple times in the past, kidneys excrete approximately 15 to 20 milliequivalents per day, but this can be greatly varying in the setting of oral intake of potassium and the intracellular uptake of potassium. For example, in the setting of low oral intake of potassium, kidneys can excrete as little as 5 milliequivalents of potassium per day. And in the setting of low serum potassium due to excessive intracellular uptake, again kidneys can sense this and they can start excreting low amounts of potassium. So the renal wasting of potassium causing hypokalemia generally tend to have excessive urinary potassium. That's going to be the basis of our workup as well, and finding out the cause of hypokalemia as well. So how the potassium homeostasis is regulated by the kidney? As I told you, absorption of potassium in the kidneys is mostly at the proximal nephron level. That is not important for the homeostasis as such, but actual homeostasis of how much potassium should be secreted and thereby how much potassium should be excreted is regulated by the distal nephron, which means the distal nephron is the most important as far as potassium homeostasis is concerned, because this is the one that determines how much should be wasted and how much should be conserved, and thereby the net urinary potassium excretion. And this is in turn determined by the very, very important channel called as renal outer medullary potassium channels, which is present in the principal cells on the distal part of the nephron, especially the collecting ducts. And activity of this ROMK potassium channels secreting potassium into the lumen is dependent on the sodium reabsorption in the same cell happening through epithelial sodium channel. This sodium reabsorption is going to create negativity in the lumen and the luminal membrane. That's going to suck out potassium, and that's how you are going to remember, causing more potassium excretion and predisposed into hypokalemia. So more the sodium reabsorption, more is the potassium excretion and hypokalemia. And we know the ENaC channels are under the control of mineralocorticoid receptors, and these mineralocorticoid receptors are under the influence of mineralocorticoid, for example aldosterone, which is the natural mineralocorticoid in the body, and the aldosterone is going to be under the control of renin and angiotensin system. So excessive activity of renin, angiotensin, aldosterone, ENaC system and mineralocorticoid system can result in excessive sodium reabsorption, thereby promoting excessive potassium excretion, causing hypokalemia, right? And we all know that this mineralocorticoid receptor can be activated by the cortisol as well, but this is actually prevented, which means the kidney and the mineralocorticoid responsive organs are actually shielded from the effects of cortisol by 11-beta-HSD2, which converts this cortisol to cortisone, which doesn't have any mineralocorticoid activity. So that is the basis of developing this apparent mineralocorticoid excess as well. So let us come back to that in some time, and we have already discussed all these things in detail. And one of the other important determinants that determine the potassium excretion by the renal outer medullary potassium channels is the distal sodium and water delivery, which means anything that increases the distal sodium and water delivery can wash out more potassium, resulting in hypokalemia. Apart from that, as I told you before, this negativity in the luminal membrane is very important in sucking out this potassium out, resulting in more potassium secretion, which means presence of certain non-absorbable anions in excessive amounts in the urine also can produce a similar mechanism of sucking out potassium from the renal outer medullary potassium channels, resulting in more potassium excretion and hypokalemia. So let us start with the basic condition that increases the distal sodium and water delivery, that is going to result in hypokalemia. Number one is going to be the diuretics, as you expect, especially the loop diuretics and the thiazide diuretics, that produces excessive sodium delivery as well as water delivery, especially by the loop diuretics, causing hypokalemia. And associated conditions that are similar to loop and thiazide diuretic use, like Bartter syndrome and Gentleman syndrome. These are congenital conditions that are going to mimic the use of loop and thiazide diuretics. We know that, and we're going to discuss in detail in the nephrology chapter. So they are also one of the important causes of hypokalemia. And they can cause euvolemic hyponatremia as well, Bartter and Gentleman syndrome, as well as chronic diuretic use. And number two, patients who are having polyuria. Polyuria due to any cause, more water delivery. That is the reason. So this also explains why certain patients with primary polydipsia, even though it's a true water disorder, it should result only in sodium problem, but also some patients show hypokalemia. That is due to excessive washout by the excessive water delivery to the distal nephron, causing hypokalemia. Clear? And this can be the reason for post obstructive diuresis causing hypokalemia. After obstructive uropathy, when you release the obstruction, result in hypokalemia. This could be the reason. At the same time, in the resolving phase of acute tubular necrosis, you will have diuresis, and this could be the same reason why you develop hypokalemia for that matters in those patients as well. So polyuria, any condition that produce polyuria can be associated with hypokalemia due to washout from the distal nephron. And it's very obvious that anything that increases the activity of renin, angiotensin, aldosterone, mineralocorticoid receptor ENaC system can result in more sodium reabsorption, hypokalemia. So obviously this is a state of a hyperaldosteronism like picture, which can be either primary or secondary or non-aldosterone mineralocorticoid excess. Clear? Primary we know, we have discussed all these things in detail in the hyper and hypoaldosteronism chapter itself, but let me recap only very important things. So primary hyperaldosteronism can be either renin mediated or not renin mediated. Renin mediated means they are renin secreting tumors, which I have discussed already, or not renin mediated primary aldosterone excess will be due to primary hyperaldosteronism itself, that is coming from the adrenal gland, zona glomerulosa. Primary hyperaldosteronism can be due to acquired cause, or it could be a congenital cause like familial hyperaldosteronism, or it could be something else like adrenal hyperplasia as well. So adrenal adenoma causing primary hyperaldosteronism is what we refer to as Cont syndrome. All of these things we have discussed in detail in the previous chapters itself. Secondary hyperaldosteronism causing hypokalemia, typically seen in renal artery stenosis and fibromuscular dysplasia, that is low renal perfusion setting, or it can be seen in the setting of diuretics. So diuretics can cause hypokalemia by two mechanisms, one by activating the aldosterone system as well as by increasing the sodium and water delivery to the distal nephron. And non-aldosterone mineralocorticoid excess, you have a lot of conditions where thereby you are going to directly stimulate the mineralocorticoid receptor bypassing the renin, angiotensin, aldosterone system by giving exogenous mineralocorticoids possible. Or it can happen in a condition where you have an apparent mineralocorticoid excess, where you have excess cortisol, not excess cortisol, you have a normal cortisol, but because of the deficiency of 11-beta-HSD2 enzyme, you can result in more cortisol activity on the mineralocorticoid receptor causing hyperaldosteronism like picture. So this can be either congenital 11-beta-HSD2 deficiency, autosomal recessive inheritance, or it could be an acquired 11-beta-HSD2 deficiency, which is typically due to black licorice ingestion, causing 11-beta-HSD2 inhibition, causing more cortisol activity. It's not a state of excess cortisol, but more cortisol activity on the mineralocorticoid receptor because the shielding effect is lost, resulting in excess mineralocorticoid activity in the kidney, causing hypokalemia and hypertension. And you have another condition called Liddle syndrome. In Liddle syndrome, it's not the problem of renin, aldosterone, angiotensin system, or it's not a problem of mineralocorticoid receptor as well. It's a problem of epithelial sodium channels, which means there will be a gain of function mutation of this epithelial sodium channels, causing more sodium reabsorption, result in hypokalemia and metabolic alkalosis, causing hyperaldosteronism like picture, but it's not due to excessive aldosterone. That's why it's called a pseudo hyperaldosteronism, Liddle syndrome. So that's a state of a non-aldosterone mineralocorticoid excess. So all these conditions can result in a state of hypokalemia due to excessive relative or absolute aldosterone activity, and all these conditions can be differentiated based on the aldosterone renin ratio and the associated algorithm, which we have discussed in detail already in the previous chapters. And non-absorbable anions as a cause of hypokalemia can be seen in the setting of excessive bicarbonate wasting in the urine, called as bicarbonaturia, because bicarbonate can produce this electronegativity in the luminal membrane, sucking out more potassium, causing increased potassium excretion and hypokalemia. And this can be seen in patients who are suffering from proximal type 2 RTA, which we'll be discussing in detail later. And it can also be seen in patients who are vomiting continuously, which we'll be discussing subsequently again. And beta-hydroxybutyrate is a ketone body, which is an anion, which can produce the similar effect, and this can be seen in a patient who is suffering from a diabetic ketoacidosis or excessive ketone bodies in general, not only beta-hydroxybutyrate, can be seen in other conditions like starvation, or if the patient is having low-calorie ketogenic diet. These things also can produce hypokalemia by a similar principle. Excessive ketone body anions causing more electronegativity, sucking out more potassium out. And hippurate is rare. Hippurate is a anion, and it's a non-absorbable anion. As a cause of hypokalemia can be seen in the setting of toluene intoxication, toluene use. So possible. Fine. So these are the conditions that produce hypokalemia due to excessive non-absorbable anions in the urine. But what you generally don't really get is how vomiting and nasogastric tube drainage or a continuous nasogastric tube drainage or a continuous vomiting can produce hypokalemia due to renal wasting of potassium. Many students believe that vomiting is a cause of GIT, reason for hypokalemia, but it's not. Even though vomitus actually happens through the gastrointestinal tract, but hypokalemia happens to the renal problem. So renal wasting of potassium. So vomiting and continuous NG tube aspiration causing hypokalemia can be due to two reasons. One is a less likely cause, like it can cause volume depletion. Because of the volume depletion, you might result in excessive activation of renin-angiotensin-aldosterone system, resulting in more sodium reabsorption. Along with that, more potassium secretion, and this could be the reason for hypokalemia. But this, as the reason for hypokalemia, is only a minor cause, that's not a major cause. But the major reason for hypokalemia and vomiting and continuous NG tube drainage is the alkalosis that is going to generate. Because vomiting and gastric secretion are something that's going to have a high amount of H plus and chloride, that is hydrochloric acid. So you're going to lose a lot of H plus from the system, resulting in a alkalosis. And you're going to lose a lot of chloride from the system as well, resulting in a state of hypochloremic metabolic alkalosis. Remember, diarrhea results in hyperchloremic metabolic acidosis, and vomiting is going to result in hypochloremic metabolic alkalosis. So this low urinary chloride is really important, because in the setting of hypochloremia, the filtered chloride will be very less, and that has a very important impact as far as your treatment is concerned, which we'll be discussing in nephrology section. So there will be a low urinary chloride. That's a very important point because of hypochloremia. And there will be a low urinary H plus in the initial stages, and there will be increased urinary bicarbonate because of the alkalosis. Alkalosis is a state of excessive bicarbonate, metabolic alkalosis. So because the patients are having increased bicarbonate, the filtered bicarbonate will also increase, resulting in more urinary bicarbonate, and this is supposed to be the main reason for hypokalemia. So as I told you before, bicarbonate as a reason, bicarbonate urea as a reason for hypokalemia happens in the setting of vomiting. So there is another thing that happens over a period of time called as paradoxical aciduria, which we'll be discussing after some time. I'm not going to discuss right now, but this is the main reason why vomiting patients have hypokalemia. Remember, vomiting causing hypokalemia is due to renal wasting of potassium. Clear? And at the same time, vomiting as a cause of hypokalemia as one important associated finding called low urinary chloride and hypochloremia as well, which will be very, very important for our workup later on. Fine. Now let us move on to the workup and the clinical features of hypokalemia. So clinical features of hypokalemia, as I have described for hyperkalemia, we can classify on the basis of severity and the serum potassium, clinical manifestations, as well as the ECG findings. But please understand the fact that clinical severity and ECG findings once again will be dependent on how fast the potassium changes happen. If it's an acute problem, the features will be more prominent and the ECG findings also will be more prominent. If it's more chronic, the clinical features and the ECG findings may not be that much pronounced. So let us see. Mild hypokalemia is defined as potassium in the range of 3 to 3.5 milliequivalents per liter. Obviously, normal potassium must be in the range of 3.5 to 5 milliequivalents per liter, which we have described multiple times in the past. Mild hypokalemia is defined as potassium in the range of 3 to 3.5 milliequivalents per liter. Clinically, patient tends to be asymptomatic and features will not be prominent in this mild hypokalemic patients. ECG features, one of the earliest findings in ECG you will see in hypokalemia is flattening of the T wave. Very, very important earliest ECG findings. And moderate hypokalemia is defined as potassium in the range of 2.5 to 3 milliequivalents per liter. Patient starts to develop clinical features in this setting like nausea and vomiting. Patients will be more lethargic and there will be start of neuromuscular weakness. Even though they will not be paralyzed, they can walk, but there will be start of neuromuscular weakness in this setting. And the ECG findings include T wave flattening, which can be persistent in moderate hypokalemic phase as well, which can progress to ST segment depression as well, which is very common in moderate to severe hypokalemia. Along with that, patients will start developing prominent U waves, which is very, very important, one of the very classic features of hypokalemia. First of all, you have to know the origin of the U waves. U waves are thought to be due to secondary repolarization of the Purkinje fibers. Remember, Purkinje fibers are extremely sensitive to hypokalemia. As I told you, atrium is very, very sensitive to hyperkalemia. Similarly, Purkinje fibers are very sensitive to hypokalemia. And Purkinje fiber secondary repolarization or prolonged repolarization of the Purkinje fibers resulting in a prominent U wave is very classic. So that is why you result in the prominent U wave, because U wave is due to Purkinje fiber repolarization. And normally U waves are not prominently seen in a normal 12 lead ECG, but in the setting of hypokalemia it becomes prominent because of the mechanisms I told you before. Whether hypokalemia produces prolonged QT or not is a $1 million question. Let us see theoretically. Theoretically speaking, yes, it can produce prolonged QT, and this is what you should answer in exams. But practically and electrophysiologically speaking, answer is no. They do not produce long QT. But why the books say? It's more often it's the prolonged QU interval that is mistaken as a QT interval. So which means the ventricles are not going to have prolonged repolarization. It's the Purkinje fibers that are going to have prolonged repolarization, producing a prominent U wave. And that U wave is what is mistaken as a T wave, and you're calculating the QT interval and you're telling it is a prolonged QT interval. So let me tell that how it is possible. So first let me draw the normal ECG, where you have a P wave, QRS complex and the T wave, and you know QT interval means you're going to start from the beginning of the QRS complex till the end of the T wave. And what happens in setting of hypokalemia? There will be a flattening of the T wave, but there will be a prominence of the U wave. So here the T waves and the U waves look like a mountain pattern. So that's also one of the common questions in exam. And if you calculate the QT interval, actually QT interval is okay here, but if you calculate the U wave also, because you mistake this U wave as the T wave, there will be prolonged QT interval, but actually there is no prolonged QT interval. It's the prolonged QU interval which you are mistaking as a prolonged QT interval, which means Purkinje fibers are the most sensitive for hypokalemia, not the ventricles. Ventricles are repolarizing okay, but the Purkinje fibers are having prolonged repolarization, secondary repolarization, phase 3 is prolonged there. That is the reason why you get a U wave in this setting. And further complicating the issue, there can be a small ST depression along with the prominent U wave. So here there is a small ST segment depression along with the prominent U wave. So here you don't see the T wave at all. So a beginner easily can mistake this U wave as a T wave. So you'll be calculating this as a prolonged QT, but actually he is not even seeing the QT. He is seeing actually the QU interval, which is prolonged. And in severe case of hypokalemia, there will be a prominent ST depression. Along with that, there will be a prominent U wave formation. So once again, you are going to interpret this as the T wave, which is not a T wave, which is a U wave, and you're going to tell there is a prolonged QT interval, which is not the case. It's nothing but a prolonged QU interval. And this pattern is what we refer to as a typical biphasic pattern, where you'll have a initial negative deflection due to the ST depression, and then you will have a positive deflection due to prominent U wave. So this kind of negative then positive kind of biphasic pattern is very classic of a moderate to severe hypokalemia for that matters. Clear? Very, very important points. So theoretically speaking, long QT, yes. Electrophysiologically speaking, actually it's not the QT interval, it's the prolonged QU interval that you are mistaking as a QT interval. But in exams, answer, hypokalemia is a cause of prolonged QT. Fine. Is there any experimental evidence or any research-based backup for this data? Yes. Long QT, if it's a true ventricular prolongation of phase 3 and long QT, is usually associated with a very classic arrhythmia associated with long QT called torsades point, called as torsades, which will be discussed in cardiology. But hypokalemia alone does not produce torsades. That itself tells hypokalemia is not a true cause of long QT. They produce only prolonged QU. But when you can result in torsades in the setting of hypokalemia, because many times hypokalemia can have an associated hypomagnesemia. In the setting of hypokalemia and hypomagnesemia, hypomagnesemia is a true cause of long QT. There is no doubt about that. That time torsade incidence is very, very high. So which means isolated hypokalemia is unlikely to cause torsades. But hypokalemia with hypomagnesemia can well cause torsades point. So a lot of experimental backup are there. So in a nutshell, hypokalemia, prolonged QT, exams, yes. Practically, electrophysiologically, no. It's a prolonged QU interval rather than a QT interval. What do you mean by severe hypokalemia? Potassium in the range of less than 2.5, where the patient starts developing neuromuscular paralysis, respiratory failure, typically a type 2 respiratory failure due to neuromuscular weakness, and paralytic ileus, and patients are prone for developing rhabdomyolysis, especially if the patient is having moderate to severe hypokalemia. Hypokalemia is one of the very, very important differential diagnosis for Guillain-Barré syndrome, especially the hypokalemic periodic paralysis part, because they come typically like a Guillain-Barré syndrome, very acute. And rhabdomyolysis can happen with moderate to severe hypokalemia. The reason for rhabdomyolysis, I've described you already. Let me tell you one more time. Potassium release from the muscle during exercise happens due to a physiological reason, because they have to produce vasodilation for the exercising muscle to receive more blood flow. In the setting of hypokalemia, the muscles will not receive enough supply, because hypokalemia will not allow the vessels to go for vasodilation, which means the blood supply will not be adequate. And if the patient exercises at the same time, there will be a gross demand supply mismatch resulting in rhabdomyolysis, which means a hypokalemic patient going for exercise can induce a rhabdomyolysis. Rhabdomyolysis can result in excessive myoglobin leak into the blood. This excessive myoglobin can result in acute kidney injury by a variety of mechanisms like vasoconstriction, deposition in the tubular cells resulting in acute tubular necrosis. So it can cause acute kidney injury. Clear? So hypokalemic patient going for exercise is a very, very important risk factor for developing rhabdomyolysis due to ischemia, acidosis, and many other things. Possible ECG findings, you will be starting to encounter arrhythmias in this setting. So in the form of PACs, premature atrial contractions, PVCs, premature ventricular contractions, or you can result in bradycardias, even though they are generally rare, in the form of sinus bradycardia or AV blocks. And they can develop paroxysmal atrial tachycardias and junctional tachycardias, and ventricular tachycardia and ventricular fibrillation as well. They can cause torsades also, theoretically speaking, but usually torsades is very rare in an isolated hypokalemia. It will be usually seen in the setting of combined hypokalemia with hypomagnesemia. There are some few individuals who are at increased risk of developing these arrhythmias, like those who are old age, elderly, and those who are having an organic heart disease like heart failure or a pre-existing coronary artery disease, or those patients who are having concomitant digitalis use. Clear? Because hypokalemia will increase the digitalis toxicity. So because digitalis and potassium are in competition for the sodium potassium ATPase binding. So in the setting of low potassium, now the competition for digitalis is not there. So digitalis will start binding with the sodium potassium ATPase in relatively more amounts, resulting in digitalis toxicity. So hypokalemia can precipitate digitalis toxicity. So one of the side effects of digitalis toxicity is hyperkalemia. So this is something very easy to understand as well. Clear? Now, what are the other effects of hypokalemia? Like as I told you, hypokalemia can produce rhabdomyolysis, especially if the patient goes for exercise. Hypokalemia can precipitate hepatic encephalopathy in cirrhotic patients. Hypokalemia is one of the important triggers for hepatic encephalopathy. Hypokalemia and metabolic alkalosis, both are very important triggers for hepatic encephalopathy in cirrhosis patients, which we'll be discussing subsequently in the hepatology section later. And at the same time, they can produce something called a polyuria. So why they should produce polyuria? Let us see. They can also produce hypokalemic nephropathy, which I'll be discussing, but why they produce polyuria? First of all, there is a very, very important transporter in the thick ascending limb of the loop of Henle called as sodium-potassium 2-chloride transporter. And this potassium has to move out through renal outer medullary potassium channels for the purpose of absorbing other cations through the paracellular route, which I have described already in detail. Suppose if there is hypokalemia in the patient, there will be low filtered potassium. If there is a low filtered potassium, there will be poor functioning of this sodium potassium ATPase, sodium potassium 2-chloride ATPase. This is called NKCC2 transporter, and there will be poor functioning of this NKCC2 transporter, because you need potassium also in a decent amount for the proper functioning of this transporter. So if there is poor functioning, there will be reduced medullary interstitial hyperosmolarity. As I told you, this medullary interstitial hyperosmolarity is very, very important for water reabsorption from many other segments of the nephron. So if there is poor medullary interstitial hyperosmolarity because of poor sodium concentration, because of the defective NKCC2 transporter, there is going to be polyuria. More water leak into the urine resulting in polyuria, which means urine cannot be concentrated without this NKCC2. At the same time, hypokalemia is thought to directly interfere with the ADH action because once ADH acts in the distal part of the nephron, they are going to act on the V2 receptors and they are going to insert this aquaporin 2 channels, thereby absorbing free water from the distal part of the nephron, which is a very important determinant of urinary osmolality and urinary concentration. It's been thought that hypokalemia can directly interfere with the insertion of aquaporin channels, thereby inducing a state of ADH resistance, which means even in the presence of ADH, hypokalemia interferes with the insertion of aquaporin channels, resulting in poor absorption of water from the distal segments of the nephron, resulting in poor concentrating ability and polyuria. So there are two reasons for polyuria. One is defective NKCC2 activity causing reduced medullary interstitial hyperosmolarity, causing poor urinary concentration polyuria. Second, defective insertion of aquaporin 2 channels inducing a state of relative ADH resistance, causing defective urinary concentration and polyuria. Clear? Apart from that, hypokalemia can maintain metabolic alkalosis, and it can also cause something called hypokalemic nephropathy. Both have a shared pathophysiology, which we'll be discussing in some time. So tubular cells can develop some vacuolar inclusion bodies in the setting of chronic hypokalemia, especially if it's prolonged for more than a month. So that's what we refer to as a hypokalemic nephropathy. So let us see how hypokalemia can maintain metabolic alkalosis and they can produce this kind of damage to the kidneys as well. So for that, we have to understand the things that are happening at the PCT level. So this is the PCT tubular cell, and on the basolateral side, you have blood that is flowing, and obviously this is going to be the luminal side. All right, and these are the basolateral sides of the PCT tubular cell. So in the setting of hypokalemia in the blood, the cell tries to compensate by releasing potassium out and thereby taking H plus in. We know that this is going to happen constantly everywhere. So which means there's going to be excessive H plus ions inside the PCT cell, which will be causing intracellular acidosis. Even though outside there can be alkalosis, you have a setting of intracellular acidosis in patients who are having chronic hypokalemia. And this is a false perception of intracellular acidosis. So what they're going to do is they're going to reabsorb more bicarbonate because PCT thinks that there is acidosis. Actually, there is no acidosis. Actually, in fact, there can be alkalosis, but because of hypokalemia, induced shift of H plus into the cell, there will be intracellular acidosis, which promotes the reabsorption of bicarbonate more and more. And this is one reason why hypokalemia can maintain metabolic alkalosis. Second mechanism, how they can maintain metabolic alkalosis at the same time, they can produce hypokalemic nephropathy is by increasing ammonia production. How they increase ammonia production? Again, due to this intracellular acidosis. Intracellular acidosis will enhance the ammonia production, which means they are going to produce hyperammonemia within the PCT cell. And we'll be discussing about this in detail in the acid-base balance. But anyways, hypokalemia is a state which produces intracellular acidosis, which is going to enhance the ammonia production. And in this intracellular acidosis is also related to one more important pathologic finding of renal cysts, because intracellular acidosis is thought to promote cell proliferation. Once the cell proliferates and there will be fluid accumulation between these cells, you are going to result in cyst formation. So that is the reason why chronic hypokalemia can result in renal cysts as well. And intracellular acidosis, as I told you, they can increase ammonia production. So hypokalemia can increase ammoniogenesis in the kidney, and hyperkalemia can suppress ammoniogenesis in the kidney. Both are very important to understand. So once you increase this ammonia production, this has multiple effects. This ammonia is going to diffuse through the interstitium, and they are going to combine with H plus that are going to be released in the distal part of the nephron. And this ammonia along with H plus ions together, they form ammonium, which combines with chloride, and they will be excreted in the urine as ammonium chloride, which means ammonium is very, very important for H plus excretion as well. Clear? So ammonium is important for washing out this H plus in the urine. So more the ammonium that is produced, more you are going to wash out the H plus. Once you deplete the H plus in the body, you are going to result in metabolic alkalosis. So this is how hypokalemia can maintain metabolic alkalosis, hence proved. Clear? So first point answered. Hypokalemia produces metabolic alkalosis. And again, how they produce cis, once again we have answered. And how they produce hypokalemic nephropathy. Once again, it is related to intracellular acidosis and excessive ammonia production. This excessive ammonia production can result in two other phenomenon called as complement activation and interstitial fibrosis. Complement activation in the tubules will result in tubular damage, and this is the reason why the tubular cells will develop this vacuolar lesions. So development of this vacuolar lesions in the kidney is what is referred to as hypokalemic nephropathy, but you can extrapolate to other findings as well. And they can cause interstitial fibrosis as well, because this excessive ammonia production is the reason for activation of various other factors like your transforming growth factor beta, MCP1 and IGBP1 and many other factors like this will be increased, and the increase in these factors is the reason thought to be behind this interstitial fibrosis. So hypokalemia chronically, especially if it's persisting for more than 1 month, can promote renal cyst formation, interstitial fibrosis and development of vacuolar lesions in the kidney, especially in the proximal parts of the nephron called as hypokalemic nephropathy. And at the same time, hypokalemia itself can maintain metabolic alkalosis. And hypokalemia can produce rhabdomyolysis, especially if the patient is exercising. And hypokalemia can precipitate hepatic encephalopathy in patients with cirrhosis. These are some of the things which are often forgotten by the student, which are very important for exams as well. Let us move on to the workup of hypokalemia. Remember, especially in life-threatening situations, workup can be done later, doesn't matter. First, you treat with IV potassium, especially in the setting of neuromuscular paralysis, respiratory failure, of the patient is having some life-threatening arrhythmias. First, treat the hypokalemia, then you can work up later. Always there is a dictum in medicine where a wrong diagnosis in an alive patient is far better than the right diagnosis in a dead patient. Life always is a priority, which is a common mistake done, especially in the early years of residency, where students think that they wanted to work up in an extensive way. Finding out the diagnosis is more important than the life, but it's not the case. Life is more important. So first treat them. Later on you can work up, or even if you don't work up, doesn't matter. First save the life. So if a patient is having hypokalemia, obviously first step is to take a proper history, which itself might give you a lot of idea. For example, a patient who is having active diarrhea, having hypokalemia, clearly tells you that there is no workup needed for this patient. Diarrhea is the reason for hypokalemia, straightforward. Or if the patient is having medications that is supposed to cause hypokalemia. For example, a patient is in DK, receiving insulin infusion, having hypokalemia, you're not going to evaluate further. Insulin is the reason for hypokalemia for that matters. Review the medications properly and rule out pseudo hypokalemia if possible. If a patient with AML or CML having a test tube hypokalemia, it's very obvious. So need not evaluate further unless and until there is a significant clinical feature showing hypokalemia. So still, if etiology is not found, if you are not able to find out any etiology after reviewing the history, medications, and you try to rule out pseudo hypokalemia but of no avail, then in this setting, it's better to find out what is the reason for hypokalemia, which means where is the potassium getting lost. So it could be extrarenal loss of potassium. Extrarenal loss of potassium, which means the potassium can be lost from the GIT. It could be a GIT root loss, which will be most of the times obvious with the history. Very common cause is diarrhea. Or it could be a transcellular shift or increased intracellular uptake of potassium in the setting of certain drugs or hypokalemic periodic paralysis. In this setting, your transtubular potassium gradient will be less than 3, which means this is appropriate for hypokalemia, which means kidneys are trying to conserve potassium. And obviously that has to be done because in hypokalemia, kidneys tries to conserve potassium, and the TTKG is also agreeing to that. Kidneys are trying to conserve potassium, appropriate for the degree of hypokalemia. Or if the 24-hour urinary potassium is less than 25 milliequivalents per day, or if the spot urinary potassium is less than 15 milliequivalents per liter. We don't really use the spot values. better do 24-hour urinary potassium or a transtubular potassium gradient. Or potassium creatinine ratio is also a good alternative, which is less than 13 milliequivalents per gram of creatinine. So in this setting, you can be very sure that kidneys are trying to conserve, which means potassium is getting lost through some other source. It's an extrarenal loss. Or it could be a renal wasting of potassium. It could be a renal loss of potassium as a cause of hypokalemia. When can you tell it's a renal wasting of potassium? Whenever your TTKG, transtubular potassium gradient, is more than 7, which is definitely not appropriate for any case of hypokalemia. Or if the 24-hour urinary potassium is more than 25 milliequivalents per day, or if the spot urinary potassium is more than 15 milliequivalents per liter, or if the potassium creatinine ratio is more than 13 milliequivalents per gram. So this clearly tells that kidneys are eliminating more potassium, and it should not do in the setting of hypokalemia, so thereby telling you clearly that it's a renal wasting of potassium. In this setting of renal wasting of potassium, you have to see the blood pressure first. What is the BP of the patient, whether the patient is hypertensive or having a normal BP or having hypotension. In the setting of hypertension, I'll be going for aldosterone ratio as the next step. This is the next and best step. Any patient with hypertension, hypokalemia, that's what I'm going to do. And based on aldosterone ratio, I can evaluate further, which I have clearly described and I've described in extensive detail in the hypo and hyperaldosteronism chapter itself. If the patient is having normal or low BP, in this setting, your acid-base status will be of vital clue, where the patient is having a acidosis or a alkalosis. The setting of acidosis, only 2 diagnoses possible. The patient might be having a renal tubular acidosis, could be type 1 or type 2 renal tubular acidosis. In both these settings, it's the renal wasting of potassium as the cause of hypokalemia, or it could be diabetic ketoacidosis. In type 2 proximal RTA and diabetic ketoacidosis, the reason for hypokalemia is excessive non-absorbable anions in the urine in the form of either bicarbonate in type 2 RTA or your beta-hydroxybutyrate in diabetic ketoacidosis. What if the patient is alkalotic? The patient is having metabolic alkalosis rather than acidosis. So in this setting, you have 2 differential diagnoses. Either it could be a diuretic use or it could be a vomiting and associated conditions, both of which can produce alkalosis. So see the urinary chloride, because vomiting is going to produce hypochloremic metabolic alkalosis. So urinary chloride less than 20, which means urinary chloride decreased, means I'm going to think about vomiting and other associated conditions like continuous Ryle's tube aspiration or nasogastric tube drainage, or probably psychiatric conditions and eating disorders like bulimia nervosa, which is going to mimic a vomiting. So if the urinary chloride is more than 20, it's high. In this setting, I'm going to think about diuretic use as a major cause, loop and thiazide diuretics, and related conditions like Bartter syndrome and Gitelman syndrome. One more important thing is the fact that whenever you have a renal loss of potassium, irrespective of the BP or acid-base status, always rule out hypomagnesemia, which is fairly important, because hypomagnesemia can lead to hypokalemia itself. So how it is possible? Because magnesium is thought to be the gatekeeper of this renal outer medullary potassium channels. We know there is something called renal outer medullary potassium channel, which is going to be the reason for leakage of potassium in the urine, potassium secretion. And magnesium is thought to be the gatekeeper. It reduces the ROMK channel activity. So whenever you have low magnesium and hypomagnesemia, your ROMK channel will be hyperactive, resulting in more loss of potassium in the urine. Clear? So always rule out hypomagnesemia. In any patient with renal wasting of potassium and having refractory hypokalemia, you have to definitely rule out hypomagnesemia. If there is hypomagnesemia, unless and until you correct hypomagnesemia, your hypokalemia will not be corrected. Now we are moving on to the management of hypokalemia, which is even more important. So obviously you are going to do potassium supplementation. So before doing potassium supplementation, there are a few things which you have to be very cautious upon. One is you have to rule out hypomagnesemia, especially if the patient is supposed to have renal losses. So correct magnesium also along with potassium. Apart from that, if you correct only potassium in the setting of hypomagnesemia, as I told you, you're not going to result in any hypokalemia correction, and there will be refractory hypokalemia. Second, always be cautious during potassium supplementation if you are dealing in a patient who's having hypokalemia due to transcellular or intracellular shift of potassium. If there is a patient who's having a transcellular shift causing hypokalemia, correction should be very slow and low because of risk of rebound hyperkalemia. Then third, you have to calculate the estimated deficit. This is applicable only in true losses of potassium. This is not applicable in patients who are having transcellular shift. In true loss of potassium from the body, you can calculate the estimated deficit. Typically, for every 1 milliequivalent per liter decrease in serum potassium, it actually approximates to 200 to 400 milliequivalents of loss of total body potassium, which means it's huge. Why is that so? Why is the discordance here? Just 1 milliequivalent decline in the serum potassium is roughly equivalent to 200 to 400 milliequivalent loss of total body potassium, because potassium is mostly intracellular. So 1 milliequivalent decline means there is so much of potassium that is coming out from the cell as well to compensate for that decline, and that is also lost out of the body, and that is the reason why this much amount of total body potassium is actually lost for every 1 milliequivalent per liter loss in the serum potassium. And while calculating this estimated deficit, you have to be cautious with associated conditions. Like for example, in a patient who is suffering from a diabetic ketoacidosis, hypokalemia may be due to insulin treatment, and very commonly during insulin treatment you will encounter hypokalemia or worsening of hypokalemia. Second, hypokalemia may worsen with correction of hyperosmolarity, because I told you hyperosmolarity is going to drag the potassium from inside the cell to outside the cell by solvent drag mechanism, which I have described in the previous chapter itself. So when you correct the hyperosmolarity and when you give insulin treatment, they worsen hypokalemia and you may need more replacement than what you estimate. So that is one important clinical point that you have to know. Similarly, in a patient who is having normal and-gap metabolic acidosis, very classically you will be seeing in a diarrhea and normal and-gap metabolic acidosis. In this setting, correction of acidosis may worsen hypokalemia, which means when you correct acidosis, which means you improve the pH from probably a 7.2 to 7.8 range, 7.4 range. So 0.2 increase in pH will be associated with 0.8 decline in the serum potassium, as I told you by the rule which I have described in the beginning of the chapter. So they can actually worsen hypokalemia and you might need additional replacement for the same. So which means how much ever you estimate, it's not going to actually reflect your true serum potassium status. So it's better always to check serum potassium sequentially and very frequently in the setting of hypokalemia to determine how much you want to correct. So but in general, overall 1 milliequivalent decline in the serum potassium is associated with 200 to 400 milliequivalents of loss of total body potassium. But you have to be very careful in the setting of DK and normal and-gap metabolic acidosis, because correction of these problems may result in worsening of hypokalemia rather than improvement in the hypokalemia. So you might need more replacement than what you're going to expect in these settings. And there are variety of formulations that are available for correction of hypokalemia. And the most common and the most important formulation that you're going to use is potassium chloride, pot chlor. So which is available as intravenous formulation as well as oral formulation. Intravenous formulations can be given either through the peripheral line or you can use a central line. If your replacements are very huge, it's always better to prefer central line. You cannot give in the peripheral line, because potassium is a very, very irritating substance to the veins and it can cause severe phlebitis on its own. Clear? So be very careful. When you are giving high dose of potassium, prefer a central line rather than a peripheral line. And how much you can replace, first you have to know how much potassium concentration you can give maximally in the peripheral line. It's approximately 20 to 40 milliequivalents per liter is the potassium concentration that you can use through the peripheral line. And you can use up to 40 to 60 milliequivalents per liter as far as central line is concerned, the maximum being 60. You cannot cross that. Similarly, infusion rate should be a standard, and you have a maximum limit also for peripheral line and central line. Infusion rate should be less than 10 milliequivalents per liter. 10 is the maximum as far as peripheral line is concerned, 10 milliequivalents per hour. And in the central line, you can go up to 10 to 40 milliequivalents per hour. This is the maximum infusion rate that you can set in the central line. So maximum is going to be 40 in this regards. 40 milliequivalents per hour is the maximum infusion rate that you can set in the central line. But one important thing that you have to understand is the fact that when you are using a central line and you need doses as high as 40 milliequivalents per hour, always prefer a femoral line rather than a jugular line. So because when you use a jugular vein in this setting, when you are using a very high concentrations of potassium, they can produce cardiac irritation and they can produce cardiac arrest because of localized hyperkalemia near the heart. So don't do that. So try to give in the femoral line. So this is very important because many times students think that central line is the most important, but it's not the case, especially when you're giving high concentration of potassium. Try to give in the femoral line rather than the jugular line. And one more important point is the fact that do not use dextrose containing solutions for infusing potassium. For IV potassium replacement, do not use dextrose containing solutions because dextrose can increase your sodium potassium ATPase activity by increasing the insulin release. At the same time, dextrose can increase ATP production in the RBCs, which can increase sodium potassium ATPase activity in the RBCs, resulting in more potassium uptake by the cells, causing more hypokalemia. So do not use dextrose containing solutions unless and until you have some specific situation, which will not be the case usually in a clinical setting. But what you can use is sodium containing solutions. NS is usually the preferred solution, but even NS has to be avoided in a patient who is suffering from hypokalemic periodic paralysis, where you will be preferring mannitol as the important diluting solution. NS is the usual solution under normal circumstances, but in hypokalemic periodic paralysis, prefer mannitol as a diluting solution. What about oral formulations? Oral formulations, you have two types of formulations, solid formulations as well as liquid formulations, syrup formulations. We generally prefer solid formulations because of their superior bioavailability compared to liquid formulations. Liquid formulation means we have pot chlor syrups, potassium chloride syrups, which are very commonly used in many hospitals and OPD settings. And one of the important side effects of this solid formulations is the fact that they can produce pill-induced esophagitis. And even some liquid formulations also can produce this, but liquid formulations have a relatively lesser risk compared to solid formulation. They can produce pill-induced esophagitis because of the osmolar injury in the esophagus, because potassium is as osmotic as sodium, which I described you in the earlier chapters of endocrine itself. And if you are using syrup formulation, you have to know the calculation. 15 ml of potassium chloride syrup of 10% KCl syrup, which means it's going to have 10% of potassium, which means 1.5 grams of potassium is what you're going to have in the 10% syrup. 15 ml means 15 gram of syrup. In that 10% is potassium, that is 1.5 grams is potassium, which is going to roughly equate to 20 milliequivalents of potassium chloride. 20 milliequivalents of potassium and potassium chloride. Clear? And you have other formulations which you can prefer in certain settings, like potassium citrate, where I'll be using in specific situation like distal RTA, where the nephrocalcinosis and hypercalciuria in distal RTA is actually due to hypocitraturia, which we'll be discussing in detail in the RTA section. But in distal RTA, you can prefer potassium citrate rather than a potassium chloride. Apart from that, you have potassium phosphate, that's called POTPHOS or KPHOS. Potassium phosphate can be preferred in Fanconi syndrome. Fanconi syndrome is a subset of proximal RTA where there will be glycosuria, amino aciduria, and hyperphosphaturia, and the patient will have hypophosphatemia. Because to increase the phosphate entry into the body and to compensate for the loss of phosphate that is happening in Fanconi syndrome, you are going to use potassium phosphate. But the problem with this is they have a lower retention rate, which means their bioavailability is a little bit less, which is approximately only 40% compared to that of KCl. So that is the reason why we don't prefer in routine settings, but they can be preferred in selected settings like potassium citrate in a patient with distal RTA and potassium phosphate in the patient with Fanconi syndrome. And there are other formulations in the form of potassium acetate also, which is very, very rarely used. Or we can use potassium bicarbonate. Or you can also use certain salt substitutes. Even some common salt also has a decent amount of potassium chloride. Like for example, every 1 gram of salt, that is 1/6 of the teaspoon, is going to have approximately 10 to 13 milliequivalents of KCl. So these are the other formulations, but in general we don't use. The most favorite and the most common formulation that we use is KCl, as both as oral as well as IV formulation. In DRTA, citrate, in patients who are suffering from Fanconi syndrome, subset of proximal RTA, you can use potassium phosphate. Apart from the other formulations, we don't use very common. Let us move on to certain cases. So this patient has a clear clinical history of suffering from diarrhea for the last 3 days, and very clear. I'm not going to work up this case obviously. And ECG showed hypokalemic changes in the form of very subtle U waves that you can see here. These are prominent U waves. So this is definitely pathological, and this much of prominent U waves you don't see in normal patients. So these are the prominent U waves that you are seeing. So this is definitely a case of hypokalemia. So which means you have a QRS complex here, you have a T wave here. This is a P wave obviously, but what is this wave? That must be the U wave. So a positive wave immediately after the T wave. Then another patient who had edema due to venous insufficiency. Patient has been started on Lasix, and the practitioners believed that Lasix was not that effective in controlling the edema, so he added thiazide diuretics as well. Once they added thiazide diuretics, the patient might go for severe hypokalemia because of various mechanisms which we'll be discussing later on in the nephrology section. But once again, this is a hypokalemic ECG, very, very clear, because there are 2 agents that can precipitate hypokalemia in this patient, and both can act synergistically as well, where you are going to see the U wave in multiple leads. So these are the U waves that you are seeing. So let us plot what you are seeing here. So this is the P wave, this is the QRS complex, and this is the T wave, and this positive wave immediately after the T wave is actually the U wave. So prominent U waves, yes, very common in clinical practice, hypokalemia. Who is a 74-year-old man suffering from constipation and came to a surgeon where they did a CT abdomen and found out to have an obstructed hernia. And this patient's potassium was only 2.1 milliequivalents per liter, which is a severe hypokalemia, and this is expected in colonic obstructions and intestinal obstructions. There will be excessive potassium secretion into the lumen, depleting the total body potassium, causing hypokalemia. And it's very acute because it's an intestinal obstruction, right? So obviously you are expecting ECG changes. In a chronic hypokalemia, even at a range of 1.7, 1.8, I have seen relatively normal ECGs because the body tends to adapt to chronic changes. But acute, generally you tend to have a lot of clinical features and EKG changes. And yes, you are seeing classic hypokalemic changes. This biphasic pattern is very characteristic. This is suggestive of a ST depression with a prominent U wave, and probably adjusted to the rate, your QU interval may be prolonged, but not the QT interval. Be very careful about that. But this biphasic pattern of ST depression and prominent U waves itself is very, very specific for hypokalemia, to be honest. And this ST segment depression in other leads can be actually manifested as ST elevation in AVR, which is quite understandable. And ST elevation in AVR can be seen in severe hypokalemia as well. One of the important differential diagnosis for ST elevation in the AVR. Usual differential diagnosis in a normal looking patient is a triple vessel disease or a left mainstem disease in ischemic settings. That is different. But ST elevation AVR, in this setting, I'll be taking as hypokalemia only, not ischemia. And at the same time, my rate is actually increased. Definitely, I'm having a tachycardia without a doubt. Why in a patient with hypokalemia should have a tachycardia? So let us review the P wave and how it is looking like in lead 2. You can see the P wave. It's not so characteristic normal looking P wave. So it's something different. So normal looking P wave in lead 2 must be something like this. So I'm seeing something different. Probably it could be an ectopic P wave. In the setting of severe hypokalemia, the setting of tachycardia, I'll be taking this as a paroxysmal atrial tachycardia, which means this is an ectopic source for the P wave and the tachycardia from the atrium. It's an ectopic atrial tachycardia, which is very common in acute severe hypokalemias. So let us see what happened to the ECG after treatment with IV KCl, and now the serum potassium became 3.6 milliequivalents per liter. Almost all the changes have completely disappeared. You can see there is no U wave, there is no ST depression in the precordial leads, because potassium related changes are best seen in the precordial and the chest leads. Clear? And there is no ST elevation in the AVR, that disappeared as well. And the P waves are now looking completely normal. There's absolutely no problem in the appearance of the P wave as well, and there is no tachycardia, completely disappeared. T waves are looking normal as well. So all the changes have completely gone. Dramatic improvement, and that's why electrolyte changes are. Once you correct these electrolytes, everything reverses completely. Let us move on to the final case. It was a 35-year-old gentleman, Gentleman syndrome, known case already, suffering from diarrhea for 3 days, and this is the EKG. Gentleman syndrome is a condition which is known for its hyponatremia, hypokalemia, but more importantly, it's known for its effect on producing hypomagnesemia as well. Not produce hypocalcemia, but they can produce hypomagnesemia very prominently. Compared to Bartter syndrome, Gentleman syndrome patients tend to have more hypomagnesemia. And diarrhea itself can cause both hypokalemia as well as hypomagnesemia. So now you have many things that can produce and precipitate serious hypokalemia as well as hypomagnesemia in the same patient, and that's how this ECG was. What you're typically seeing is classic hypokalemic changes. One is the T flattening. Definitely this is a flat T without a doubt, because normal T wave must be something like this. Something like this. This should be the normal T wave, and this is definitely a flat T wave, no doubt about that. And you're having a prominent U wave as well. So this is definitely a prominent U wave. So if you plot, this must be the P wave, and this must be the QRS complex, and this must be the T wave. And what is this wave? So this must be the U wave, for that matters. That's the U wave. Clear? So you're having a flat T with a prominent U. That tells you that patient is definitely having a hypokalemia. Doesn't matter. But hypokalemia generally doesn't produce long QT. If you ask me whether this is a long QT or not, I will surely tell this is a long QT. So this is surely a QT prolongation. And I'll tell you the trick on how to diagnose a QT prolongation in the setting of a normal sinus rhythm, but not in the setting of a tachyarrhythmia. Remember, when you take the two RR intervals and you draw an arbitrary line at the midpoint, you should have the T wave that should happen before the midline that you're drawing. So let me draw separately. So let me tell a normal rhythm for that matters. Let us assume this is a normal rhythm. So as per the information I gave, when you put a midline from these two QRS complexes, so a normal T wave must always be before the midpoint that you're drawing arbitrarily like this. This is an arbitrary line. This is not a line that will be given in the ECG. This is an arbitrary line that you have drawn, but you have understood that this is the midpoint between the two QRS complex and the and the RR interval. So the T wave should always be falling before that midpoint that you have drawn. But here the T wave is actually falling on the midpoint, or it's slightly beyond that midpoint that you're drawing, the end of the T wave. So that tells you the patient is probably having a QT interval, but you have to see the numbers in the ECG that will tell you whether the QT interval is prolonged or not. I will take this as a prolonged QT only. Why the patient should have a prolonged QT? So hypokalemia tends to produce prolonged QU interval, but it does not produce prolonged QT. To be honest, it's unlikely to produce prolonged QT. If you have a hypokalemia and a true prolonged QT, there must be hypomagnesemia as well. That's why I gave the history. History is clearly suggestive of hypomagnesemia. So patient must have hypomagnesemia, and we suspected hypomagnesemia and took a serum magnesium level which was only 0.9 milligrams per deciliter. Normal magnesium is somewhere around 1.7 to 2.3 milligrams per deciliter. This is a normal magnesium, serum magnesium, but it's only 0.98, just half of the usual magnesium. That's why this patient is having a QT prolongation as well as QU prolongation. That is suggestive of hypokalemia. Along with that, the patient is having ST depression a little bit, T flattening along with the prominent UA. All these are suggestive of hypokalemia as well. So that is backed up by another finding in this ECG, that this patient developed a transient tossards. So this is a TDP, tossard pointer. And tossard pointer in a pure hypokalemia is very, very rare. And whenever a patient is having hypokalemia along with hypomagnesemia, tossards become very, very common. So that's why this case is very, very important. A true QT prolongation along with tossards suggests that this patient is not having only hypokalemia, they are having hypomagnesemia as well. Clear? So we have covered hypokalemia extensively in this video. Let us stop here and let us move on to the next topic on obesity.